Right. Hello, 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 everybody. I'm going to give folks some time to join, and we will begin shortly. Everyone who is joining us, we are going to begin at 5:05, just to make sure we give time to some folks who are joining us soon. All right. Good afternoon, everybody. We want to thank you so much for joining us today. We appreciate you taking the time to participate and engage in this thoughtful discussion as we come together under the recognition that we all deserve care without fear. We come together under the notion that however your pregnancy ends, everyone deserves support and the tools necessary to navigate pregnancy with self-determination and with dignity. We recognize that Georgia's maternal health crisis, whereby over 80% of pregnancy-related deaths are preventable, is unacceptable. Where the state-sanctioned violence lingers in our maternal and reproductive health deserts, it lingers in our policies that restrict care through limitations on abortion access and the criminalization of pregnancy outcomes. It lingers in Georgia's failure to expand Medicaid, leaving over an estimated 240,000 Georgians without health insurance. It lingers in our communities, particularly that of Black women, who are dying at over 3 times the rate of pregnancy-related causes than white women. It lingers in our providers who are shackled by Georgia criminal and penal law, which has compromised their medical autonomy and their ability to deliver care. We remember Amber Thurman. We remember Candy Miller, who were 2 young mothers whose deaths were preventable, but care was denied or delayed due to a fear of prosecution, resulting in their deaths. We remember Adriana Smith, who was kept artificially alive after being declared brain dead because she was pregnant while her family had no say as to her end-of-life care. It lingers in cases in the countless of women and birthing people who are experiencing coercion, loss of autonomy, care delayed or denied, obstetric violence, and provider shortages across the state. The Know Your Rights campaign was created to confront these injustices, bring together cross-sector leaders to equip Georgians with the tools to navigate a restrictive and often hostile reproductive healthcare landscape, because we all deserve joy, not fear. So with that being said, we extend our deepest gratitude to our esteemed panelists here today, not only for dedicating your time and expertise to enrich this webinar, but also for your passion, your commitment, and your partnership in advancing this movement during such a challenging time. So I welcome you to Protecting Visitation and Decision-Making Rights for Birthing People in Georgia, a reproductive justice approach. All right, so today you are going to hear about Georgia's maternal health crisis. You're going to hear about legal planning. You're going to hear about informed birth planning and also a labor support training. We will have some time for Q&A at the end at a total of 10 minutes towards the end. So who are we? SisterLove is the first women's HIV and sexual and reproductive justice organization in the Southeast, founded by the wonderful Dazon Dixon Jallo, who is a trailblazer and advocate. And she founded SisterLove in 1989 to eradicate the adverse impact of HIV and sexual and reproductive challenges, particularly impacting Black women, women of color, and marginalized communities. We work through law and policy, we work through research, and we work through healthcare and services. The Justice Law and Policy Project was established in 2025 as a direct response to the escalating attacks on our civil rights, our reproductive health, and our bodily autonomy, especially in today's political and social climate. We work by drafting policies at the local and state level. We work by providing public legal education, conducting grassroots organizing, and collaborating with other experts within the field. We are grounded in the principles of movement lawyering and reproductive justice, and we were created to meet this movement with courage, strategy, and vision. And through RJ, we center our communities in order to ensure that we honor the rights, the autonomy, and the dignity of all people. So what is reproductive justice? What is the approach that we're taking for this legal webinar today? RJ is a term that was coined in 1994 by a collective of Black women activists who formed the Women of African Descent for Reproductive Justice. RJ recognized that the mainstream reproductive rights movement, which at the time focused predominantly on choice rights, failed to understand the intersecting inequalities shaping their lives. As such, they created this term that is grounded in social justice, human rights, and intersectionality to create a framework and a lens for us to analyze how multidimensional things such as gender and multidimensional identities such as gender, race, class, sexual orientation intersect to shape one's ability to control their reproductive destiny. So just because you have the right to access abortion, just because you have the right to access healthcare, just because you have the right to a fair and free education, that doesn't mean you have the access to it. Different intersecting identities, such as your gender, such as your race, such as your class, such as where you live, where you have your life, right, can certainly play a role in your ability to access that. And so RJ was coined in order to provide a lens for this framing. How does it work? So the 4 core tenets of RJ are the right to have children, the right not to have children, the right to parent in safe and healthy environments, and the right to bodily autonomy. Before we begin, I would like to provide you with a legal disclaimer. The information in this webinar is for educational and informational purposes only, and it does not constitute legal advice. Participation in this session, including asking questions or receiving general information from presenters, does not create an attorney-client relationship between you and any presenter, organization, or affiliated entity. Laws and regulations related to civil rights, reproductive health, and related issues are subject to change rapidly, especially given the current political and legal landscape. While every effort has been made to ensure the accuracy and the timeliness of the information shared, we cannot guarantee that all content reflects the most current legal developments. For guidance specific to your individual circumstances, you should consult a qualified attorney licensed in your state who can provide advice tailored to your particular situation. Last, with respect to the Q&A, questions will be addressed in the order received, and we will have 10 minutes at the end of the webinar. We hope that we maintain a space that encourages open, considerate discussion and mutual respect throughout the session. Thank you so much for joining us today. It is with honor that I introduce to you Gabrielle Albert, Executive Director of For Cure for Moms, who is going to set the stage for us. Thank you, Gabby, so much for joining us.
Thank you, Gabriella. And so good evening, everyone. So I'm going to set the stage on Georgia's maternal health crisis. But before I do that, next, I'm going to actually set the stage for the U.S. crisis, because that is the sad reality. The U.S. has the highest maternal mortality rate in the industrialized world. I'm going to say that again. The highest maternal mortality rate in the industrialized world, and we're the most expensive to actually give birth. The fact of the matter is over 700 women die every year in the United States, and 84% of those deaths are preventable. Next. And we know what that means we know what those causes are. The maternal mortality rate continues to increase. You'll see that it peaked in COVID, comes down, slightly goes back up. But the reality is we've been hovering around that 650 to 700, and that's too many. What we like to say is, if 2 747s went down today, the United States would do everything to make sure whoever did it was punished. So why are we allowing this to happen in our own backyard? And that's the state of the United States. And in the United States, Black women and brown women are 3 to 4 more times more likely to die. Unfortunately, next, that sets the stage for Georgia. Georgia is not better. It's actually worse. And so what are those reasons? Number one, Georgia is poor in healthcare overall. It ranks 38th in America's healthcare rankings. And Georgia's maternal health, it's worse than that of the U.S. Unfortunately, we like to trade with some of our sister states between top 1 to 7 over the past 5 years. We've seen it number 1, we've seen it number 3, we've seen it 5. Most recently, they'll say it's 7. It's too high, and we know that. And the disparities across basically all of the social determinants of health are the reasons why. We know that there's racism and implicit bias. Racial disparities continue to persist, with Black and non-Hispanic infants experiencing the highest maternal mortality rates. It's still here in Georgia where Black and brown women are facing the highest maternal mortality rates. We've got the abortion ban, mentioned the women that unfortunately lost their lives simply because we are not giving people bodily autonomy. There's extreme lack of access to health care and insurance here. Georgia has one of the highest shares of residents for under 65 without health insurance. Our poverty rate is above the U.S. average of 11 to 12. We're at 13.5 to 14%. And education, unfortunately, is average to below average, anywhere from 26 to 30 in educational rankings. Next. And so when we look at that, and when we look at Georgia specifically, we know that access is the right now leading issue. Out of every 10 women in Georgia, 9 of them could have been saved. We know what to do. The CDC is in our backyard. They know that fact of 84%. They have a campaign called Hear Her. We're not listening to women. But in Georgia, it's not only that we're not listening, we don't even have the places to listen to them. 93 rural counties have no hospitals without labor and delivery units. 82 counties, more than half, don't have OBGYNs. 40% of Georgia is considered maternity deserts. And 2 to 3 rural births happen outside of the home county. And for those, maternity desert means you have to travel with over an hour to get to a labor and delivery unit. And so we're averaging over 30 8.2 deaths a year and 21 versus the 21 deaths nationwide. Next. The March of Dimes does an annual report card. The 2025 should be launching any day. But last year, we can see that our preterm birth rates were 45th out of 52. It's an improvement, but it's not an improvement enough. For preterm disparity ratios, also they are slightly better, but not where they need to be. Infant mortality, 43rd of 52. And it got worse. And it got worse in the Black and Brown communities. 32 deaths a year. We're at 31 out of 40 in terms of rank, because not all 50 states are considered. But again, we trade back and forth and we're trending way too high. We also know that not only do we not have the proper access, but low risk cesareans are being had. And what that simply means is they're giving cesareans for everything. And why? Cesareans are actually the lucrative part of labor and delivery. But this is where we're going to get into the solution today, is when you advocate and know for yourself what to do, you don't have to have a cesarean if someone's recommending it. You need to figure out why and what are your alternatives before that. And it goes back to our rate. I said 84% is the nation. We're 87 to 89%. We know what to do, but we've got to do better. Next. And so when we get into even more of the statistics and more of the issues, the disparities in healthcare. So cardiovascular conditions, they're the leading cause of pregnancy-related deaths from 2020 to 2022. And cardiovascular conditions are accounting for 50% of the maternal deaths. So we're talking, that can also be, that's across pregnancy and the postpartum. So preeclampsia, high blood pressure, all of those things, hemorrhaging, are all causing more concern and more deaths. Prematurity in our infants, it was 22.1 in 2019. It's at 16.2, but we've still got a long way to go. Maternal gestational diabetes is increasing as well. And this also goes into, when we talk about access, we know that Georgia also has a lot of health issues. I'm sorry, not health, but we've got a lot of grocery and deserts and food deserts that appear. And we're seeing that because pre-pregnancy obesity rose from 39,000 to 42,000 in 2022. And in the conditions we're currently in, we know that healthcare and nutrition is only going to get worse, but it's something that we can all impact. STDs, we're 5th in chlamydia and gonorrhea and 20th in syphilis, which is extremely high, and that can lead to premature labor and uterine infections. And untreated STDs, going back to access, it increases the risk of miscarriage, low birth weight, and stillbirth. So all of these factors are correlating. We also see that postpartum depression rates in Georgia, they decreased, but then they increased in 2021. You know, unfortunately, numbers are always later. So we know COVID, it raised, but it would be interesting to see where they come out over the next few years. Intimate partner violence is another area that is plaguing specifically in reproductive health. And IPV is linked to obviously negative maternal and neonatal outcomes. And 3.6% of women experience this in the year before pregnancy. And we know it's also happening in the postpartum. We're going to hear access throughout today, prenatal care and access. So the Kolachek Index, which measures prenatal care adequacy, Albany has the highest rates of inadequate care at 24.4%, and Georgia ranks 32nd for access to prenatal care. Only 76% of lives receive adequate care. That means over a quarter are not. Next. And we mentioned labor and delivery. Only 36% of counties have L&D. OBGYNs, only 1,363 OBGYNs are licensed and currently practicing, and a significant portion are nearing retirement. And if the state of Georgia is in millions, so put that in perspective, we don't have enough OBGYNs, which is why today's discussion, when we talk about alternate care, doulas, midwives are going to be so, and community navigators are going to be so important to solving the crisis we see here in Georgia. Representation matters. Of that, OBGYNs, we also know that racial distributions, 47% are white, 21% are Black and African American, and the rest are other minorities, which doesn't represent the needs that we have here in Georgia. Breastfeeding rates are also lower than the national average. And another area which is very much often overlooked, but it goes back to overall healthcare, is oral health. 76% of women actually had dental insurance, but only 27% had dental cleanings. Dental care is so important, and it's something, especially when you're pregnant, that needs to be looked at, because periodontal disease is linked to adverse birth outcomes and cause significant complications. And then insurance and Medicaid, we're 49th. We'll say that again. We're 49th. We're last. Only difference between us, we're not dead last. We're last. And we're fighting to be dead last for uninsured women between 18 to 44, with 17.5% uninsured. And one of the facts here is to understand that pregnancy is not actually considered a emergency coverage. It doesn't change your coverage. The birth does. So when we talk about not having prenatal insurance, it's a correlation here. So as we get into this insurance benefit period, we know that the marketplace exchange is not great, but please, please, if you're considering getting pregnant or you're working with women who are expecting or want to get pregnant, this is the time to get something, because if you have an emergency, it causes a lot of issue. You're supposed to be covered, but we also know here that if you don't have hospitals nearby, where are you going to go? And then we also have WIC participation has increased. So we know that poverty is increasing, and then also vaccination rates. Georgia's flu vaccination for pregnant women is 40%, 40.8, but it's below the national average of 59.6. And COVID vaccinations, only 7.3% as of last year. So the reality is the results are staggering, but we know what to do. And so next, that's exactly what Fork Here for Moms and all the organizations represented here to do are about. And I'm just going to remind you that we believe that through education, advocacy, and legislation, we can make a difference. So make sure that you educate yourselves and spread the awareness that there is a maternal mortality crisis. Make sure that you understand how to self-advocate, but more importantly, it takes a village. When it's time to think about your health, it shouldn't just be a conversation between you and the mirror. You need to make sure that you have an advocate who understands your health concerns, that's outside of your doctors, so that someone can be there with you and help you through and navigate this landscape. And we also have to hold our legislators accountable. So we know next year when the Georgia legislation comes back in, there actually is a maternal health momnibus package. So we should all be making sure that that's pushed, because it's going to address all of those access and disparities that we talked about. Thank you.
Thank you so much, Gabby. Thank you so much for that important setting the tone for this webinar. As Gabby described, there is an importance of also knowing your rights, knowing when you have informed consent, which is absolutely always, and knowing when you can withdraw that consent. And so an aspect of this webinar is legal planning. Megan and I will be speaking to you about advanced directives, about Georgia's pregnancy exclusion laws, as well as Adriana's law. Kind of want to set the tone a little bit for this Know Your Rights specific section. I want to let you know that it is widely recognized by Georgia statutory law, by U.S. common law, and by U.S. constitutional law that everyone has the fundamental right to decide what medical treatment they will accept or refuse. This right includes the ability to make their decisions known in advance, especially when it comes to providing direction to healthcare providers in the event that they cannot or they choose not to speak for themselves. So traditionally in Georgia, we had a living will and a durable power of attorney. However, back in, I want to say 2005 to the period of 2010, around that time, the Georgia legislature decided to execute this document in an easier way and a more convenient way for Georgians to be able to name a person to make medical decisions for you, known as a healthcare agent, and also state your preferences for medical treatment if you are unable to do so yourself or you don't want to make them yourself. So this is the Georgia Advanced Directive for Healthcare Form. Soon, a member of the the Sister Love team will be sending out some resources, and you can click on a link there that will provide you with direct access to the Georgia Advanced Directive for Healthcare. By effectively filling out this legal document, you can control aspects of your personal care, your medical treatment. You can insist on or decline treatment, and you can direct that medical treatment be withdrawn.
Hey, y'all. All right, I'm going to talk a little bit about the pregnancy exclusion laws, which are, we'll talk a little bit, it might sound like a bummer at first, but we're going to talk about ways that you can work around this. So the pregnancy exclusion law in Georgia, it's a state statutory provision that somewhat limits the ability of advanced medical directives for pregnant patients. This can compel, in some cases, unwanted medical intervention in the perceived interest of fetal life. We have this problem all the time. We have this problem across maternal health, but we have this with this law. We're prioritizing infant-centric care over maternal-centric care. And that's one issue where this comes into play. So the way that this shows up in Georgia is that if you become terminally ill and incapacitated, any medical decisions that are in your advanced directive, if you are pregnant, can be disregarded if you do not have a specific pregnancy instruction. We'll talk a little bit more about that on the next slide and how to make sure if that's something you're interested in, that you put it in your advanced directive and ways to communicate that. And then if your pregnancy, once it is considered viable, that can invalidate your advanced directive. Law compels it to be invalidated. Obviously, as we know in all of these cases, physicians are making their own sort of determinations, but that's what the law says. The law says that if you have a viable fetus, that your advanced directive, the state takes over control of your care and your advanced directive is null and void. And again, if you are pregnant pre what's determined viability and you don't have a pregnancy specific instruction in there, in the event that this happens and I'm pregnant, I want this to happen, they can disregard your end of life directives. So if we move to the next slide, we can talk sort of a little bit about what that looks like when you are looking over this. So one of the great things about Georgia is, as Gabby mentioned, there is a form that you can fill out. It's pretty comprehensive. I want to say, first of all, if you're a pregnant person and you don't want to worry about this, you don't have to worry about this. You can interact with this as much or as little as feels comfortable to you. And also, we're going to talk about this a little bit when we talk about the healthcare agent, but as Gabby mentioned before, you don't have to be the one to think about this either. You can talk about this with a person you want to designate for your care, and that person can worry about it. So that's just something to be thinking about. But what it does mean is if you're a pregnant person and you are trying to get pregnant, this is something that you are worried about. You want to make sure you have that pregnancy specific instruction in your advanced directive. There's no specifics on what that can be. If it's not, Georgia doesn't consider it violating its law, then you can have that be whatever it wants. Just make sure it's in there so that it's not disregarded. And then just know, once you are getting to that sort of viability standard, that's the point at which you might not see people honoring those advanced directives. But again, I think that's why we'll talk a little bit more on later about your healthcare provider. But if this is something that you, as the pregnant person, it feels overwhelming to think about, I know I was that person, you can always have somebody else come in and do that. And that's kind of just where pregnancy exclusion is in Georgia. And we're going to talk a little bit more about, Gabby will talk a little bit more about what we can do about this and everything too.
Okay, so what can be done? So the law can be changed to ensure that people's decisions and end-of-life care are honored throughout their pregnancy. So I'm going to speak to you a little bit about Adriana's law and how that's showing up not only on the congressional level, but how it will be showing up in the 2025 and 2026 legislative session coming up soon here in Georgia, beginning in January. So we certainly want folks to know about that. Outside of that, we can educate the public and encourage end-of-life planning. The fact that you are here in this webinar, you are learning, you are educating yourself. This is something that will translate at the dinner table. It will translate in spaces with your friends and spaces with folks that you are safe and comfortable with to talk about these things. And so as you continue to learn from our esteemed panelists, I encourage you to continue to share this information. And of course, through the Know Your Rights campaign, we will be hosting future webinars as well on different topics associated with reproductive health and care and RJ, of course. And so we certainly want you to encourage other folks and to help them understand their rights, encourage these conversations with loved ones, and create plans for your care. Outside of that, we focus on ending racial disparities and ensuring respectful maternity care for all. Denying people the ability to make decisions during pregnancy does not improve the stark disparities Black birthing people in Georgia face. It doesn't improve any stark disparity, and it certainly does not remove the maternal mortality rates that we are experiencing here in Georgia, nor nationwide. So Adriana's Law, as I spoke to you a little bit about Adriana, in the case of Adriana earlier, Adriana was a Georgia nurse and mother. She was declared brain dead while about 9 weeks pregnant and was kept on life support, so artificially kept alive until at least 32 weeks gestation because of her pregnancy. This reached the congressional ears. This reached national news. It was a major thing here in Georgia with folks angrily protesting because her family described that they had no say as to her end of life care. So as a result, Representative Park Cannon here in Georgia, as well as our congressional representative, Nikema Williams at the congressional level, introduced these resolutions, both of which are titled here today, HRES 522 at the 119th congressional level, and then Georgia House Resolution. Right now, we are not privy to the actual bill number. However, once the legislative session starts, I'm sure the Georgia General Assembly website will be updated. But if you want to follow along, I recommend that you connect with Representative Park Cannon. So what is Adriana's Law? Adriana's Law is a policy reform that, if passed in Georgia, would restore advanced directive rights for pregnant people and repeal laws prioritizing fetal rights over pregnant people. I do want to plug in that how Megan described, if you have an advanced directive, right, and your advanced directive is going to be adhered to, it would need to be in a case where your pregnancy is not viable. So it's not to say that that your advanced directive won't be respected by healthcare providers if you are pregnant. It's if you're pregnant and your pregnancy is viable, it will not. I also want to plug in and highlight that if it is not viable, then we recommend highly to put in that pregnancy-specific instruction, because even if it isn't viable and there is no pregnancy-specific instruction, providers can still choose not to adhere to your directives. But it is important. It is certainly important to share this advanced directive to anyone that is involved in your care. So that is the person in the room, your partner, the doula that you are working with, of course, your healthcare providers as well, whether that's a OBGYN, your doctor, the nurses, and make sure that there is a copy kept for the record, and that you have this sort of conversation as well with your labor and support team. Outside of that, Adriana's Law also points out that laws granting rights to fetuses, they strip pregnant people of autonomy and put medical decisions in the hands of politicians. And we have seen this time and time again with abortion. We have seen it with pregnancy exclusion laws. We have seen it with laws that criminalize, such as personhood, that criminalize pregnant persons for pregnancy outcomes. These decisions need to be between the person, your family, and your healthcare providers, and should certainly not be in the hands of the state. And so what our call to action is for you to contact your Georgia representatives in support of Adriana's Law, and of course, support reproductive freedom proposed legislation such as the RFA in Georgia.
So this comes back, I wanted to touch a little bit before we sort of close out this session. about the legal portion of this, about hospital visitation. So this form that's shown here, which will be included in materials that go to you guys, it is for Compassion and Choices. They are an organization that does a lot of great work around advanced directive planning. And this is an authorization form that is particularly helpful if you have someone who's not traditionally recognized as a family member, and you want them to have visitation rights. So you can keep this with your advanced directive, but it's a good form. And then just to keep in mind, you do have the right always to have somebody designated as this, even if it is not a family member. It can be anybody who you care about, who you feel comfortable doing that. If it's not a family member, this form is going to be your best place to go to make sure that that's best protected. I think, yes, this is the much not cooler part of it, but this gets into sort of, I'm going to hand it over to some people who can talk more about actual labor support and things like that, and this in the more practical.
Thanks, Megan. Hey, y'all. I'm Danielle, and I am a birth doula. I'm a certified community doula and a perinatal patient navigator. And forgive me in advance, I'm kind of on the tail end of a sinus infection, so hopefully I won't go into a full-blown coughing fit with you guys while talking. But if I do, I have my water. So I'm going to talk to you guys about creating a birth plan and also knowing your birthing bill of rights. As you've heard while we've been talking, I mean, you guys have a voice, and we definitely want to make sure that you guys use it. For anybody out there who is not familiar with what a doula does, a doula is not a clinical provider on your team, although we are trained in physiological childbirth. So we do know what's going on, right? But we are there to provide that continuous physical, emotional, and informational support. And we are also there to help you advocate for yourself. So your doula is not the one who is speaking up for you when you're in the birthing room, but we are teaching you and educating you on all of your options so you are able to advocate for yourself. All right, so let's get into it. So, what is a birth plan, you say? I'm going to use birth plan while speaking to you today, but for the most part, I actually like to call them preferences, birth preferences, because I feel like things when you think about a plan, sometimes you can kind of think like that plan is concrete, but just know and understand that even though you are creating a birth plan, that plan can be fluid and it can change and things can pivot. But for the most part, it is going to be what your main preferences are during your time in labor and delivery. So we're going to call it a clear outline of your preferences for labor, birth, and the postpartum period. It's going to open communication with your care team. It'll help you feel seen, heard, and respected. And it's going to clearly communicate what matters most to you, right? So what you want is not necessarily going to be what the person in room 138 wants, right? So it's going to be what matters to you, what makes you feel seen, what makes you feel heard, what makes you feel respected. What is it about the experience that you're looking forward to? It's, as I mentioned before, it's also flexible. Birth can be unpredictable. It usually is. It's never going to go textbook and according to plan, but your values and your voice are going to stay constant in what it is that you desire for yourself and your baby. It's going to help your care team understand how to support you physically, emotionally, and sometimes culturally, right? So we're all different people. We're in different areas of our life. We're in different spiritualities. There are cultural things that happen that can be different from person to person. And you want to be able to communicate that with your birth team so that they're able to understand and also respect that. You want to keep it short, one page usually. You want to make it positive and focused on your preferences, but not necessarily demands. Historically, in Atlanta, we used to have what was called baby-friendly hospitals. Like Atlanta Medical Center was one, DeKalb Medical was one, but we know Atlanta Medical is no longer with us, and really DeKalb Medical isn't either because Emory bought them. There were a couple of hospitals who were kind of used to the things that you're going to see on the sample birth plan, but there are some that are not. But I feel like doing this work for the last 10 years, I feel like a lot of providers and nurses and people who are at hospitals now kind of understand that things have changed and are progressing more, but you still want to have these things in place. So again, you want to make it about your preferences, not necessarily demands, because you want it to be positive and not necessarily go into the room like you're absolutely running the show, but low key, you're running the show. Just know that. Next slide. So why does the birth plan even matter? So it's going to set the tone for your birth environment. You may, if you say you're birthing in a hospital, you may not want all the fluorescent lights on, right? It may be too sterile of an environment for you. So you may want calm lighting. You may want the lights dimmed. Soothing sounds. You may want to have a playlist going with sounds of nature or your turn up playlist. It just depends on you. Whatever it is that you need, it's going to set the tone for what your environment is like in your birthing space. It's going to clarify your comfort preferences. Do you want to move about? Do you want to eat? Do you want to use hydrotherapy? And also understand that even when you're in certain spaces, like they may tell you, oh, well, you know what? I think you should just focus on ice chips. Well, guess what? You need energy when you're birthing a baby. So you actually need to eat there. And we'll talk about it in the birthing bill of rights. You have the right to eat. So if people tell you that you need to be surviving off of apple juice and graham crackers while you're in labor, that's not evidence-based research. You can let them know. It's going to protect your emotional space. If you want to minimize the interruptions to ensure your privacy, so say you're with your doula and things are going great, but every 2 minutes you have a nurse coming in, and then the intern comes in, and then the resident comes in, and then the OB comes in. Like if you want those interruptions minimized, you can place that on your birth plan. They only need to come in when absolutely necessary. You have the right to say that. And it's going to center your connection with your baby. So immediately upon delivery, you're going to want that immediate skin to skin time. If you want to delay the cord clamping, you can do so. If you want that first hour for just you and your partner and the baby, that's also, available to you. As long as there isn't an emergency, you should be fine. One thing that I always tell my doula clients is there's two questions that you can ask. Am I okay? Is my baby okay? If the answer to both of those questions are yes, you're fine. Everything else can wait. All right, next slide. So this is a sample birth plan that came from Baby List. I know a lot of people, if you're pregnant or know pregnant people, Baby List. But I thought it was nice and concise. As you can see, it is one page. There's clear, and if you can't see it clearly, I think that Gabby provided links. Yay, thumbs up. So you'll be able to see that. But there are clear sections. There's a section on if you have any, medical conditions, like, do you deal with asthma? Did you have preeclampsia? Is that the reason that you're there? Just simple things for a nurse or a provider who's coming in to be able to look at and notice about you that may alter, what it is that they need to do when actually assisting you during delivery. In the labor section, there's going to be, things like, do you want to be able to move about? Do you want continuous fetal monitoring or do you want intermittent fetal monitoring? Like when you have continuous fetal monitoring, that's when, they have the contraction monitor and the heart rate monitor strapped to you, and you're usually most likely in the bed. But you can also request that they come in and, use a Doppler to actually detect the baby's heart tones. These things are available. Sometimes you just have to know to ask for them. There's a section on the delivery. So again, do you want delayed cord clamping? Do you want immediate skin to skin? Do you not want the baby to have a bath? So you can rub the vernix in and get all those, antimicrobial properties that the vernix provides to the baby's skin. All of these things are available to you. And again, sometimes you don't know what you don't know. I like to say that to my clients. So it's important to do the research on these things so that way it's easier for you to know what it is that you want and would prefer when you get into your birthing space. And even in the case of a C-section, right, you still have options. There's a family-centered cesarean. I'm not sure too many providers in Atlanta do that anymore, but that was when they used to have, turn down the lights in the OR. Music could be playing softly. Do you want the drape lowered so you can see your baby, being removed? You could still do skin to skin. Again, those are options that are available to you that can make that space a little bit more calming for you in case of. All right. And then when it's on one page like that, it's just easily shared with others. So again, if a nurse is coming in or a tech or, your OB or your midwife, whoever it is, it's much easier to hand them this one page document with these clearly delineated sections of what your preferences are versus, 4 pages of a dissertation that you typed out that they are most likely not going to read. So we want to make sure that it captures their attention and that your wishes are respected. All right, next slide. All right, so I'm going to talk about just two kind of sample birth plans. One being a natural low intervention birth. So for me, the options that you see here remind me of what would happen during a home birth or birthing at a birthing center. Typically, midwives have more of a hands-off approach when it comes to labor and delivery. And so a lot of these things are natural to them. They're not really things that you would have to necessarily over advocate for because it's something that they're used to in the way that they care for you. So, when having a home birth or birthing at a birthing center, one thing that you're going to be able to do, like I mentioned before, you're going to be able to move around. You're going to be able to walk up and down the halls or around the neighborhood, up and down steps. I like to say gravity is your friend. Gravity helps baby descend, right? You're going to be able to eat. We know that you need energy in order to deliver your baby. You're going to be able to stay hydrated. Like all of these things are important. It's something that you wouldn't have to over advocate for. Dim lighting in your home or like a suite in a birthing center is usually it's just natural, right? There's music, there's affirmations, there's birth balls available. Most likely they're going to be using the intermittent monitoring. So that's when they're going to come in with the Doppler, listen to baby, make sure baby's heart rate is tolerating those contractions well. And then they're going to go about their business. There's minimal vaginal exams. If anybody here has had a child before and they have had cervical exams, you know how uncomfortable those can be. And so they're not going to be checking every hour to see, how much have you dilated every hour. It's just not necessary. Your pain management, there's going to be comfort measures usually first. There's going to be breathing techniques, hydrotherapy. Do you want to relax in the tub? Do you want to get in the shower, let the water hit your belly, run over your back, run over your shoulders? Your doula or your partner can provide that counter pressure on your back if you're having back labor. And again, we're going to just try to make sure that you're moving about versus, going to these the medical types of pain management first. There's usually not a epidural. Well, I'm not gonna say usually. There's not an epidural in a birthing center or a home birth, so that wouldn't be an option. Sometimes there is medications that are provided. Shanti, chime in real quick if I can't remember what it's called.
Medications during labor.
Yes, for like that
GBS?
the no, so like dang y'all, forgive me. It's gonna come back to me randomly, and I'm probably gonna like type it in the chat. New vein is what I was thinking about. She said I love New vein. So yeah, so sorry about that, but I knew it would come. Blame perimenopause. I blame everything on perimenopause, y'all. But that's another webinar. All right. So there are those that medications that midwives can provide, but it's not a full-blown epidural, right? But it is available to you. All right, next slide. So also in that kind of low intervention birth plan with your birth purposes, you might want to, instead of that coached pushing, there'll be spontaneous pushing, right? Like babies know that they have to come out. Like that, we're gonna count 1, 2, 3, 4, 5. Like that actually isn't necessary. When you get personal time, I want you guys to YouTube the fetal ejection reflex. It is a fantabulous thing to see. It is absolutely just a miracle. Like when a baby is just time to come out after crowning, like the baby will just literally shoot out. It's not, as dramatic as you see on TV, but literally there is something called the fetal ejection reflex, and it's real. And it's super awesome to see when you see it in real life. If there's a choice of positioning, right? Do you want to be on hands and knees? Do you want to be standing up? Do you want to be in the shower? Do you want to be at the sink? Do you want to be in the tub? Like these are things that are not uncommon in a home birth or a birth center birth. There's immediate skin to skin and delayed cord clamping. If your partner wants to catch the baby, like the midwife is usually going to involve you, and it's really a community when it comes to birth. Like everyone is involved, and it's just a beautiful experience. In the postpartum period, that golden hour is uninterrupted. There's breast and chest feeding support, and the baby is usually right there with you because you're either in your house or the birthing suite. So that's something that we can see, or some options that we can see in a natural low intervention birth. And not to say that these things can't happen in a hospital, but as we transition into the next slide, you'll see it just may look a little bit different. All right, so next slide. So I like to call this one your flexible informed choice plan, right? So think about, so if you are birthing in a hospital, one thing that you want to always be sure of is that you are informed of all of your choices and options, right? So discuss those options at each stage. Informed consent and refusal is a thing. Your OB should not just be walking into the room saying, this is what we're doing, full stop, right? Again, am I okay? Is my baby okay? The answer to both of those things is yes. Then guess what? We can wait, or we can do this, or we can try this alternative. You just need to know what all your alternatives are. You can be open to medical pain relief if you need it, right? So in a hospital, the anesthesiologist is there. We're not saying epidurals are the worst thing on the planet. If that is something that you choose to have, then that's absolutely available to you, right? But just be open to that when and if you need it. Start with movement first. Start with that hydrotherapy first. If you have a doula on your support team, most likely we're going to exhaust all of those options first before just moving right into the epidural. Excuse me. We're going to exhaust all of those options first before moving right into the epidural. Nitrous oxide is also available to you. If you've been to the dentist before, it's the mask that they put on with the laughing gas. And it just kind of, it takes the edge off just a little bit, but obviously it's not like an epidural where you'll be confined to the bed. All right, next slide. I'm gonna take a sip of water. So with those birth preferences, right, you want to speak to your provider and you want them to explain any interventions that's mentioned before they just decide to throw them on you, right? So instead, your provider comes in, oh, well, you're not dilating fast enough. I think we need to add, a little Pitocin to the mix. And before ordering that and just going back out, to the nurse's station, they should be telling you what that means. They should be telling you what that looks like. Explain that to me. Let's discuss this. Make sure that your partner is always present for all decisions being made. The last thing you want is for them to come to you with something important. And your partner's in the restroom or something and is missing it, but you're also in the middle of a contraction. So you're not really listening because you're also in, the most intense pain of your life, thus far, right? So you want your partner or your doula to be there to make sure that you're able to receive all the information that's necessary for making the decision. And then we talked about delayed cord clamping, let them know that that's something that you're interested in. And in the postpartum period, talk about those newborn procedures. So talk about, the eye ointment, the vitamin K, circumcision, any of those things. Make sure you just do your research so that you're prepared to let your health care team know what exactly it is that you want in the hospital setting. And then make sure you talk about the emphasis on bonding and recovery time. So you want your baby in the room with you. You want your baby skin to skin. We know that these have benefits, especially when it comes to, the establishing a breastfeeding relationship. So talk about those things beforehand. You can talk about those things at prenatal appointments with your provider, and then also again when you get to the hospital setting. All right, next slide. So the Birthing Bill of Rights. So this is actually something that is not something that somebody just made up somewhere and threw on Google, right? Like this is actually real. And it's actually in every hospital. If you don't have it on you, you literally can request it. So don't go into a hospital setting or even any other type of birthing setting not understanding that this is something that your healthcare team is actually privy to. So the first thing is respectful care. You have the right to be treated with dignity and compassion, especially during, one of the most intimate times of your life, right? Like growing an entire human and birthing that human is a big deal, and so you have the right to be treated with compassion during that time. Again, like we talked about before, you have the right for informed consent and refusal. Nothing should be done to you without your permission. Nobody should be coming in to tell you, hey, I'm about to do this cervical check to see where you are. Well, I need you to pump your brakes because right now, I really don't want that done. There should not be hands being inserted into you over and over and over and over again if it doesn't need to be, right? A supportive environment. Choosing who is present during your birth. Do you want your partner at the birth? Do you want a doula at your birth? Do you want your mom at the birth? Do you want your dad at, like, whoever your tribe is, they should be allowed to be there with you. Thankfully, we are, out of COVID-19 times. So it's not like that. Oh, well, you can only have one person in the room. Most hospitals have gone back to allowing, your partner and that support person in the room. If you're at a home birth, obviously you can have the whole neighborhood there if you want to. When Shanti speaks talking about choosing the right provider, that's something that you have to think about. So if you want a whole tribe of people in your in your room with you, maybe the hospital isn't for you, but she'll talk to you about that. Freedom of movement. You have the right to labor and birth in positions that feel right to you. If you have an OBGYN, they went to medical school. They can catch that baby while you're on your hands and knees. I promise you they can. You don't have to be on your back. I promise you they can. Privacy and safety. You have the right to control who touches or who observes you. Just because you're giving birth at a teaching hospital does not mean that there need to be 20 residents and interns in the room watching you have your baby. If you are not comfortable with that, then you can advocate for yourself and you can just request that it is the nurse and the newborn team and your provider. It does not need to be the whole entire class of 2026 in your room. Evidence-based care grounded in science and not convenience. If you guys are not familiar with evidencebasedbirth.com, they're one of my favorite resources. They have resources on anything from inductions to gestational diabetes to circumcision to vitamin K injections, all the things that your doctor talks to you about. There are articles on evidencebasedbirth.com that are just that, evidence-based. It's neutral. It's not, this is what I think, and oh, but what if you try? No, it is science-backed, it is evidence-based, and it is just clear and neutral. If you have questions about anything, I please check that site out. It's a landmine of information. I love it. Cultural and emotional safety. Your values and your identity matter. So who you are, whatever your values are, again, like we talked about before, whatever your spirituality is, whatever your culture, your nationality, whatever it is that matters to you, it's yours. You own that. You get to feel seen, you get to feel heard, you get to feel respected, and all of that. And you have the right to be yourself, to be authentically you. And then you also have the right to speak up, ask questions, or file complaints if you feel like your rights are violated. There are patient advocacy teams in hospitals. Feel free to talk to them. excuse me, if you feel like those complaints have been violated. And this is a great segue into Shanti because I'm about to have a coughing fit.
All right. You still got one more slide, Danielle.
It's good. I'm literally tearing up. I'm good.
Okay. Okay. All righty. Thank you. Hello, everyone. My name is Shanti Moore, and I am a certified nurse midwife. I'm a doula, and I am the birth justice training and curriculum coordinator with Sister Song. And as part of my role, one of the things that I do is facilitate a labor support training specifically for families that don't have access to doula care for whatever reason, whether it be financial or they just haven't been able to locate a doula. So what I want to do is just really kind of focus on the advocacy piece of this training because you'll see next slide as we progress that some of the information is really kind of geared towards the comfort measures. That are involved in supporting that birthing person, as you can see here. But again, I wanted to pull out certain things like ensuring the delivery room is not crowded. And that was one of the things that Danielle just mentioned. But I want to focus on that delivery room period. And we're looking more so at a hospital setting when we're talking about this, because as Danielle mentioned, some of these things, if you are giving birth in a birth center or if you're having a home birth, you're just not going to run into some of the same issues. But one of the most important things that I think a pregnant person, a couple of family can do when they're entering into the hospital to give birth is not to enter prepared to go to war. And I know that might be counterintuitive, especially with all of the things that we hear that happen in the hospital setting. And I know that the onus should not be on that birthing family to make sure that things are uneventful. However, being forewarned is being forearmed, and just having um, a positive mindset walking in makes more of a difference than you know. And one of the other important things that I think you can really do when you're first arriving to that floor is establish rapport. Establish rapport with the nurses that you're working with, whoever's a part of that healthcare team, because again, the goal is to make sure that you have a healthy and safe delivery as uneventful as possible. And you'd be surprised just um, how willing staff may be to connect with you in that way, especially once they realize that you're not there to fight with them. Uh, And again, I hate to frame it in this way because the onus should not be on that family. But again, this is what we're dealing with. So managing that room, next slide. Managing that room is important because there are a lot of things that will happen. Like Danielle mentioned, in that hospital setting, you've got doctors, you've got nurses, you've got um, people from admin coming. They want you to sign papers, they want you to do all of these things. And as that support person, one of the most important things that you can do is protect the work that that birthing person is doing because it takes a lot of focus. So when there's someone from administration who comes in and they want you to sign papers and you notice that that birthing person is in the middle of a contraction, it's okay to say, excuse me, hold on 1 minute. They just need a minute. Give them a minute to get through this contraction and then they can talk to you about whatever. Or if it's a nurse who's coming into the room and wants to give medication and I've seen this happen. Well, they'll just start sometimes to give you some pills or put something in the IV, and it's okay to say, "Hey, can you let us know what that medication is? Can you tell us what this is for?" because that birthing person is not going to be able to advocate for themselves in that way. Um, let's see. Next slide. And we can progress to the next one as well. So knowing your rights, doing your research ahead of time about that hospital and about the provider that you're working with is really important so that when and if emergent situations do arise, you have had some thought about what to do ahead of time. Um, and I'm thinking about something else that Danielle mentioned about, like, say, um, your provider decides that they want to give you a C-section for whatever reason. They feel like baby is not responding well. We need to progress a little bit further. I wanted to introduce the concept of shared decision making because that's something that every provider is taught and something that should be incorporated when they're presenting you with certain options. And it's okay to say in the moment, hey, um, I know this is something that you feel like in your professional opinion is something that we need to do, but can we have a minute? Can we have a minute to discuss this between? And you always have that time. Don't let anybody rush you into making a decision without your full understanding of what it is that you're doing. And it's okay to say, hey, I need a minute. But going back to researching those doctors and the hospitals is really important also because when you're in that pregnancy phase, there are certain conversations that should be happening then, as opposed to waiting to get to the hospital. Like when you're talking to your provider, so what happens if at 36 weeks my baby is breech? What does that mean for me? Because you have some providers, that's an automatic cesarean section. They're not delivering breech babies. Having conversations like, can I have a VBAC? Can I have a vaginal birth after a cesarean section? These are questions that you want to ask ahead of time. If for whatever reason, I don't know, I'm trying to think of another scenario. If I'm pregnant with twins, are you going to give me a trial of labor, or is that an automatic cesarean section? And again, this is the reason why doing that research ahead of time is really important so that if you are presented with these types of situations in the moment, you have some idea about how your provider will handle them. Also, you can research the hospital's Bill of Rights because hospitals should have a Bill of Rights that you can access. And if for whatever reason you can't access that Bill of Rights from the hospital, you can also go to your Department of Health because they should also have a patient Bill of Rights that you can access. And it's really important to know as much as you can before you go in because you will have hospital staff that will tell you what you can and cannot do, and they don't even know. And that has happened to clients of mine before. I remember being a doula for virtually actually for a mom who was literally pushing. I'm on the phone, she's on hands and knees, and they're telling her you can't be on hands and knees. And the only way that she was able to continue to labor in the way that she wanted to was by saying, I can't turn over, I can't do this. So knowing your rights before labor can just help to eliminate a lot of these things. There was a resource also that I wanted to offer, the Georgia Birth Advocacy Coalition, for people who are not familiar. And their website is georgiabirth.org. And it's a wonderful resource which will lay out all of what your rights are as a birthing person. Something else that comes to mind when you're researching your hospitals, make sure that they have what you need. Like if you put on your birth plan that you want to be able to get up and move around and you want to use portable electronic fetal monitors. Yes, that hospital may have them, but it's important to know whether or not they work. because sometimes that stuff arises too, where there are certain tools that you should have at at your disposal that for whatever reason the hospitals they may have, they may not. Um, let's see. Filming is another thing that's really important to find out ahead of time, because you will have some, and I've found more so than not, more often than not, that when baby starts crowning, if you pull out your phone, that team is likely to say you can't film. You can't film in here. Find out ahead of time, because I really do believe intuitively that's to protect them from liability more so than anything. Because when you're filming conversations, you're catching everything that's happening in the room. And they may tell you that you can take pictures, but they don't want anything recorded. So find out ahead of time whether or not that's something that you can do, if that's something that is important to you. Let's see. Some other things to be mindful of. Um, please forgive my long pause. One other thing that I will bring up, just very briefly, for same-sex couples, because this is something that has come up previously, where I remember there was one couple that participated in this training that talked about giving birth. This is a lesbian couple giving birth, and when it was time to sign the birth certificate, there was no place for the mother who did not give birth to sign. And so they signed under adoptive parent, which became an issue for them later on when it was time for them to receive their FMLA benefits, and their employer was looking for adoption paperwork. So, one of the things that you can do if you are a same-sex couple, having your marriage license with you when you go to the hospital, and also making sure that if you are in that situation where there is no place for you to fill in the role, who you are to that child, that you don't sign in a place that does not apply to you. Even if you have to scratch that line out and put who you are to that child, so that you can avoid certain situations like that. And I believe that is the last slide that I have.
All right. Thank you so much, Shanti, and to all of our panelists for being here with us today. We are going to move into the Q&A function. The Q&A has been enabled for folks to be able to ask questions. It is loading on my end. So if you have any questions at all, I will provide about 2 or 3 minutes to generate them, and then we'll go ahead and start answering them. If not, then we'll move into final remarks and we will close out this session. Cecily, I see that your hand is raised. Are you able to navigate through the Q&A and type in your question by chance?
So Gabriella, she might need to go to the chat. I'm in the Q&A and it says the organizer has disabled new discussions and has disabled responses to posts. So I don't know if she'd be able to or not, but I know the chat room was open.
Okay, maybe we can pivot to the chat. I'm creating a discussion. Let me see. Let me see if I
Okay.
can. Let me see if I can quickly do this.
See, I'll just test it real quick and see. Okay, she said she just posted. Yeah, mine worked. I don't see hers.
I I see it. I can read it out.
Thank you, Raina.
The question is, I was abused by a traditional midwife. How do you hold someone like that accountable since they have no licensing? What is the best way to proceed legally?
So just so I know when I guess it would depend on how they got their licensing, but when I had a midwife, I know she did still have a formal license and I could still file, like you could still file a complaint in that the same way you would like a doc. If you were to open it up with a doctor, you would go in and file a medical complaint like online. And I know, but I think that's CNMs only, possibly. So that might not be helpful for this particularly. I don't know if anybody has anything for more traditional.
Yes, because traditional midwives are not licensed in the state of Georgia. There's no board that you can contact for traditional midwives or CPMs.
I could see that being a mechanism for advocacy. However, Cecily, I am very sorry for the experience that you had with a traditional midwife. But I can see that being as a form of advocacy. I know that we're working on a bill right now at the Georgia legislature. We're still working on analyzing the bill itself within, you could say, like the doula and midwifery professions. However, the bill would work to license traditional midwives. And I know that that's something that we've worked on with BMMA, for example, as well as Sister Song and licensing and grandmothering in traditional midwives in that regard. So if you would like to get in contact with me, please do. I can certainly connect you with folks to be able to uplift this story, and maybe change things in Georgia. Of course, I'm going to work on getting you some links. Yes, I certainly will. Thank you so much for sharing that with us tonight. We have room for a couple more questions. I'm going to leave some more time and I'll work on getting those links to you.
There's another one. Are there avenues for men to gain knowledge on the doula process in order to support their partner from contraception to the actual birth of the child?
Gabby, I'm throwing this one right to you for Cure for Dads.
Yeah, so For Cure for Dads is the new website and tool. It's a website and app. It's free to anybody. It's an online self-guided curriculum split by what we call quarters because we're using the sports and the locker room themes for men, but it really is quarter one, trimester 2 through postpartum. Quarter 3 will actually launch this weekend, and quarter 4 will be live by the end of the year. So Q1 through Q4, and then early next year, we'll have what we call warm-up pregame and then postpartum as well. And we partnered with doulas, we've partnered with midwives, we've partnered with Count the Kicks, with plenty of different organizations that you can go and leverage that. That is an actual just online program. And we also had 4 in-person workshops earlier this summer And we will be redoing some of those next year where we bring in doulas. Danielle came by. We also had somebody from the probate court. So we talk about all of these issues that we talked about today in depth, but within kind of like 3-hour sessions. It's free food, there's giveaways, and that's for Here for Dads. And then there's also, if you're interested in a full doula training, there's a Dads to Doula program, and it's Dads to Doula that's virtual that you can enroll in as well.
Don't forget the Daddy Olympics on Saturday.
Oh,
Gabby.
thank you. Exactly. And so for Here for Dads, we will be live at Baby Palooza, which is at Gas Out Arena. It's in Gwinnett, but everything is free. We're going to have free diapers. We're going to have a dad game. So think about Olympic style games for dads. This morning we were on ATL Live and did a swaddle contest. We're going to have a baby bump contest where dads got to put on medicine balls and sit up and sit down. We're going to have trash can diaper basketball, just different events, because Fork Here for Dads is based out of the lived experience. Charles Johnson, he lost his wife 9.5 years ago, and he's raised his both of his sons 18 months and 10 hours. And he knows what it's like. And we also recognize that 84% of preventable deaths, like I mentioned, we're not listening to women. So how do we reposition fathers and men in that space? Because men are making decisions about our bodies. So why not leverage it in a positive manner, but teach them the tools and the education that they need? Because during the pregnancy process, everything we see out there is all geared towards women. And then it's all geared to about infants, which rightfully so, but there's a third power, right? We like to say, if you put that together, you create a trilogy that can really help for that 84%. So please, and I'm a reference, it's free, because we call this the year of the dads. There's actually been a few different dad doulas, and I'll put my email because I can get you in touch with some more organizations, but this one is free, and we are here in Atlanta. We can come out to churches, we can come out to different environments if you've got locations, but we have a combination of virtual and in person, and you'll continue to see more events like the dad games, bringing more men into, like, what we say it takes a village. Thanks, Danielle.
Gabby, that is a word. When you said that men are left out of these decisions, but they're making decisions about our bodies, that is 100%, 100%. So thank you so much. I'm gonna go ahead and ask if we have any last minute questions, Raina, before we go ahead and close out this session. I think we have one comment in the chat. Thank you so much, Dazan. Oh, Gabby, this is someone's asking, what was the date and time again?
Yes,
I think that's for Saturday.
Yep, it's this Saturday, and it's going to be 10 to 2. And you can go right on our website at Fork Here for Moms, and the flyer is there. If I can post it on here, I will. I'm not sure if I have that ability. And you can follow us at Fork Here for Moms on Instagram. It's fully posted on there.
Raina, are there any more last minute questions before we go ahead and close out?
Nope.
All right, all right. Well, we want to thank you all, to everyone who participated, and to our panelists for joining us here today for the first episode of Know Your Rights. You deserve care without fear. You deserve care that is joyful, and you deserve the care that you want and you desire. Together, we're building the tools and the power to make that a reality across Georgia. Stay tuned for episode 2, and until then, take care and keep fighting for care without fear. I have sent in the chat a list of links I want to make sure that I uplift specifically the Maternal Health Tribunal. This is a tribunal that we will be hosting later on in March of 2026. The idea of the tribunal is to participate in narrative healing so folks and community members can tell their stories and their lived experience related to maternal health disparities. So that's whether you have experienced any sort of loss of autonomy, any sort of coercion, any sort of obstetric violence or discrimination. You can tell your story. This story will be an aspect of that healing, and you can hold the state accountable for this experience. And from there, we will be advocating at the Georgia State Capitol in order to change our laws and to keep the decisions in the family and with each other and with our providers and not with the state. And so with that being said, I want to inform you that you will be the first for participating in this webinar. You will be the first to receive our legal toolkit that will launch, I want to say, towards the end of November. And this legal toolkit will explain everything that was discussed today, including the birthing plan, including having different templates for how to create a birthing plan, the birthing bill of rights, of course, some labor and support tips, and predominantly it'll focus on a how-to guide that'll explain the legal jargon and the advanced directive. So everything that Megan and I talked about today, you'll have an in-depth resource on how to fill that out, how to ensure that your medical decisions and the decisions you want for your medical treatment are adhered to and respected, and that will be coming out in late November. So if you want to continue to stay in contact with us and attend the next webinar, please look at that resource that was sent in by Raina Patterson, and I'm going to go ahead and just send over our stay in touch form where you can make sure to stay updated on the Justice Law and Policy Project's upcoming webinars and workshops. Just to kind of give you a sneak peek, the next one that we will be conducting will also be in partnership with If, When, How, and we're hoping to get a few other organizations that predominantly focus on pregnancy criminalization, not only for pregnancy outcomes such as miscarriage and stillbirth, but also for substance use as well. And then outside of that, we'll be providing some workshops on abortion access. So certainly we want to disambiguate and demystify Georgia's abortion ban exceptions that you can say, along with it being ambiguous to start with, resulted in delayed care and denied care for many, including Amber Thurman and Candy Miller, who Candy Miller was unaware that she could go to the hospital to seek emergency life-saving care under Georgia's abortion ban, and she died in her home. And Amber Thurman, her doctors themselves were trying to decide at what point they could intervene to save her life, and 20 hours passed before they intervened and she died on the table. And so we want to ensure that we are mobilizing our communities. We want to thank you for being here with us tonight, because that shows that not only are you here to educate yourselves and to be in community and to resist the reproductive violations that are occurring across the country, but at the same time, we are serving ourselves and we are serving our communities. So thank you so much to our esteemed panelists. And I am putting the form in the chat right now if you would like to stay connected. And please, my email is there if you want to connect with Danielle Allen, if you want to connect with Shanti Moore, with the Gabby Albert, or with Megan Hill, please let me know, or you can directly reach out as well. Their bios are in the invitation link, and it'll be a quick 1-2 where I'll connect y'all as well, or you can connect directly with them as well. So thank you so much. And on behalf of the Justice Law and Policy Project, on behalf of SisterLove, we thank you for your time today. Bye, everybody.
Thanks, everyone. Good night.